Dr. Nola Locus. She's a consultant anesthetist from Northwick Park Hospital in UK. She had her postgraduate anesthetic training at the Imperial School of Anesthesia in London, including 2 years as obstetric anesthetic research fellow at the Chelsea and Westminster Hospital. She is the honorary secretary of the Obstetric Anesthetists Association and chair of the Education Subcommittee. She is the obstetric anesthetic representative in NICE Caesarean Section Guideline Updates 2011 and Intrapartum Care Guideline Updates 2014. She is a member of working group who defined the pathway of care of the critically ill parturients in 2011. She serves in editorial board, International Journal of Obstetric Anesthesia. Welcome, Dr. Nola. Dr. Nola will present us a topic, the practical and cardiovascular implications of managing the obese parturient.
Hello, everyone. Can you hear me? I've got teenage daughters, so I'm used to raising my voice, but I hope you can all hear me. Thank you for inviting me here. It's a real pleasure and an honor to be here in Kuwait. So my topic today is the practical and cardiovascular implications of managing the obese parturient. So I'm going to try and cover the epidemiology of obesity in pregnancy. I'm going to discuss some of the specific cardiovascular issues, in particular sleep-disordered breathing. And then I'm going to try and present some practical solutions to manage the obese parturient. Now, we're all familiar with the classification of obesity, but really when we're talking about obesity as a problem for clinicians, whether you're an anaesthetist, a cardiologist, an intensivist, we're really talking about those women at the extreme end of the morbid of obesity. So women with a BMI of at least greater than 40, but increasingly we're seeing women with BMI of 50 plus, 60 plus, and even 70 plus. Now, I would caution you a little bit about using BMI, body mass index, as your only marker of how much of a problem a woman presents. A few things we haven't clarified with regards to obesity in pregnancy is whether or not we should be using a woman's booking weight to calculate her BMI, or whether we should be using her term weight, what she weighs at the end of the pregnancy, to calculate her BMI. In addition, body mass index doesn't give us information about the distribution of body fat, and it can underestimate or overestimate body fat depending on the muscle mass of a patient. So as BMI is only part of the solution, and we all really need to take a close look at these women individually. Now, we know that worldwide obesity is a significant problem. This is a really great website. It provides lots of useful information. It's one of the many international collaborations going on to look at how, as an international community, we can address the problem of obesity. And it's not very reassuring currently. The UK has, in women of childbearing age, obesity rates of about 27%, Egypt 48%, and here in Kuwait 44%. Now, something that's quite good on this website is it also presents data on childhood obesity. Now, not so many countries collect data on childhood obesity, but if you reproduce this graph for girls, I can tell you that this problem isn't going to go away. Now, obesity matters because it makes a big difference to obstetric outcomes. It makes a big difference to maternal and fetal outcomes. And all of these outcomes are increased all of these fetal outcomes, neonatal outcomes, are increased in the obese parturient. So an obese woman is more likely to have a stillbirth, a preterm birth. She's more likely to develop complications, and she's more likely to have a placental abruption or caesarean delivery. Now, a bit more specifically, looking at some of the problems, with every 5 to 7 increase in body mass index, of pre-pregnancy body mass index, the risk of developing preeclampsia doubles, which is very significant. And once you get to a BMI of greater than 30, which is incredibly common, I would say it's almost standard on UK labour wards for every woman to have a BMI of greater than 30, the risk of developing gestational diabetes triples. Now, of concern for us as anaesthetists and people who provide care at the time of delivery, there's a linear relationship between body mass index and caesarean section. So as your body mass index increases, your chances of having a caesarean section goes up in direct proportion. Now, I'm just going to talk briefly about the cardiovascular implications of obesity. Now, it's difficult to separate out these problems because really one causes the other, and it's just really a circle of pathophysiology. But to try and describe the specific cardiovascular problems, I have broken it down into three areas. There's the simple mass effect of obesity, just carrying a bit more weight. There's the pathophysiological problems, and then there's the additional comorbidity that can develop. Now, in terms of the mass effect of obesity, people are just simply carrying a greater load. So there's just going to be a greater hemodynamic pressure stress on the myocardium. You have increased metabolic demands by the additional adipose tissue, and this leads to a hyperdynamic circulation with increased blood volume, and then increased preload and left ventricular afterload. Now, obesity leads to increased adipose tissue, and this is laid down in the traditional parts of the body subcutaneously. But it's also laid down in other organs around the body, so all organs will have additional fat deposits contained within them. And this can impair tissue and organ function in two ways. Firstly, the size of fat pads around key organs can increase substantially, and this can make organ function compromised simply by compressing that organ, or because some of these fat cells can actually secrete locally acting hormones. And then there's the issue of lipotoxicity. So, as I said, look, obesity can lead to the accumulation of adipose tissue in non-traditional sites, the heart, the liver. And really, lipotoxicity describes a situation which is related to the abnormal metabolism of triglycerides, fatty acids, and lipids, such that you get the build-up of lipid intermediates such as diacylglyceride, ceramides, and fatty acyl CoAs, which can impair cellular function, causing such things as apoptosis. Now, in addition, obesity causes cardiac remodeling. We know that it's associated with an increase in atrial and ventricular size, and this leads to a dysfunction in the systolic and the diastolic phases of the cardiac cycle. And you can get significant left ventricular hypertrophy. Now, the last thing I want to touch on with regards to cardiovascular morbidity is the associated comorbidities that can develop. Now, it's important for us to remember that adipose tissue is not just a benign tissue form. It's actually a separate endocrine organ that is capable of synthesizing and releasing a variety of predominantly harmful hormones that can increase the risk factor profile of a patient. So these hormones can lead to dyslipidemia, hypertension, glucose intolerance causing diabetes, and other agents which can lead to a prothrombotic state. So I think you can see easily how comorbidities such as hypertension, diabetes, and cardiovascular disease develop in any obese parturient patient. Now, I do want to mention sleep-disordered breathing. This has become, it's not that it's increased in prevalence, it's just that I think the medical community have had a much greater awareness of this as a specific problem in the obese patient. So sleep-disordered breathing describes a spectrum of conditions, hypnea, apnea, up to the far end of the extreme, obstructive sleep apnea. So this is characterized by upper airway collapse and obstruction during sleep associated with recurrent oxygen desaturation. So the prevalence of obstructive sleep apnea, although we don't really have absolutely accurate estimates, it has been suggested to be anything from 0.7 to 7%. But once a woman becomes pregnant, the rates go up to rates as high as 20% have been described. So what is the problem? Why does sleep-disordered breathing cause a problem? Well, it seems to set up a cycle where sleep interruption and intermittent hypoxia leads to significant hormonal changes in the body. These hormonal changes lead to endothelial abnormalities, glucose dysfunction, and dyslipidemia, and this leads to our poor pregnancy outcomes. The hormones that have been implicated include activation of the hypopituitary adrenal axis, increased sympathetic stress, increased oxidative stress, and increased systemic inflammation. Now, sleep-disordered breathing has been shown very eloquently in this very nice systematic review. 5 cohort studies, almost 1,000 participants, and they looked at perinatal outcomes in women with obstructive sleep apnea, and it's bad news. These forest plots look at the risk of preeclampsia in parturients with obstructive sleep apnea compared to women who do not have obstructive sleep apnea. And you can see clearly, I don't know if we've got a pointer. Is there a pointer? I think if you look at the bottom diamond on both of these forest plots, obstructive sleep apnea is very definitely a significant risk factor. And similarly with neonatal outcomes, it's fine, don't worry, I can make... It's fine. I just want to highlight the forest plots, as you know, are a graphical representation of a series of studies. And if you're not familiar with forest plots, oh yes, brilliant. Thank you. The best thing to look at is this bottom diamond, which gives you a summary of all the studies. And the bigger the diamond, the greater the effect size. So whenever you look at a forest plot, always look at that bottom diamond. And as you can see, obstructive sleep apnea is associated with a much greater risk of preterm birth. Now, the next part of my talk, I just want to talk about some management strategies that could be employed to look after the obese pregnant woman. So this is some recommendations that have come in the UK, and this is what they say. Pregnant women with a booking BMI of greater than 40, which is, I don't think that's uncommon on our labour wards, I think it's very common, even at 40, should have an antenatal consultation with an obstetric anaesthetist so that potential difficulties with venous access, regional or general anaesthesia can be identified and a management plan made. Now, we've used the BMI of 40 as a cut-off in the UK, and I run our high-risk clinic in my own hospital, and I can tell you this is a huge workload of patients, and it increases month on month. And I've been in discussion with my obstetric and cardiac colleagues about whether we should put this threshold up to 45, just because of the workload involved. But at the moment, we seem to be sticking at around 40. Now, our main remit as anaesthetists is the provision of labour analgesia and anaesthesia for caesarean section, so I want to try and answer some specific questions. Labour analgesia is important for these women, and I'll explain why in a moment, but the questions that I want to address are: how can I get an epidural or spinal in? Will I need special equipment? And should I do it very early on in the woman's labour, or shall I just only do it when and if she requests it? So why is labour analgesia useful in the obese parturient? Well, I'm going to be talking about cardiovascular implications for pregnancy in a little while, but as we know, there are some very significant physiological changes during pregnancy, and these increase even more when a woman is in labour. So that during labour, a cardiac output increases by 10% in the early first stage, but it increases to as much as 40% in the second stage. In addition, these women will often need additional monitoring for their babies, so if a woman has good pain relief on board, it can help to improve her tolerance for internal or tightly external monitoring devices. So what are the challenges in the provision of labour analgesia, particularly epidural analgesia? We know obese parturients is going to be difficult. Now, this is a fairly old study now, and I'm going to show you some newer data, but this data from over 20 years ago now, actually 30 years ago now, suggested that there was a 42% failure rate with initial epidurals in obese parturients as compared to 6% in non-obese controls, and that more than one attempt was required in almost 75% of patients. Now, there is some good news, because the same group that I've mentioned in the previous work, they've repeated their work in 2014, and they found that the epidural failure rate, has decreased to 17% in 2014, and the necessity for general anaesthesia, so that's when their regional anaesthetic techniques fails at caesarean section and they have to do a GA, that's decreased to 3%. So I think the good news is that we are, as a community, getting better and more skilled at managing these obese ladies. Now, how can you get the epidural in? I think there's no magic to it. I think it's experience and trial and error, but these are the things that I find useful. I wouldn't recommend the lateral position. Does anyone, raise your hand if you routinely do your epidurals in the lateral position? I think most people these days. Does anyone do them in the lateral position? Raise your hands if you do them routinely in the sitting position. Okay, sitting, yeah, I think sitting has it. So I think when you've got the patient in the sitting position, the adipose tissue falls to one side. We know from ultrasound studies it guarantees the shortest distance to the midline. One thing I would say is that higher spaces in these patients tend to be easier than the lower lumbar. So in these patients, for epidurals alone, not for spinals, I would tend to go for a higher lumbar space, L1, 2, L2, 3. What about ultrasound? Now, it's difficult to pick up any journal wherever you live or work in the world without that journal containing at least one article about ultrasound, and we've certainly heard about ultrasound on this course. Now, we've got an ultrasound machine on our lay board, but certainly in the UK, it's been suggested that we don't use ultrasound as much as we should for the provision of neuraxial blockade in labour. So what can ultrasound do? Well, it can help us to identify the midline. It can assist with identifying the correct level. So if you're worried about going too high, it can tell you where you're going. It can help you measure the depth of the space. But we know that ultrasound in the obese parturient is more difficult simply because you've got more tissue to get through to be able to look at what you actually want to see. But there is some evidence. This is a smallish study looking at pre-procedural ultrasound in obese parturients compared to non-obese parturients. And what this group found was when they used ultrasound before they did their epidural, they increased their first attempt success rate. 92% when ultrasound was used and only 44% when they didn't use ultrasound. So I have to say that I'm trying to make it a standard part of my practice in those very obese parturients, certainly with a BMI of greater than 50, to do pre-procedural ultrasound. And I think there's another reason to try and increase your use in its practice is that if you increase your use in its use in your standard practice, when you really need to use it, when you're really in trouble, you'll have much greater skills. Now, will you need special equipment? Will you need extensive selection of longer needles? Well, I have to say that in general, most of our standard needles do seem to work. The one thing that I would urge you to consider getting is a slightly longer spinal needle. Most of our spinal needles are around the 11 centimetre mark, but some companies do market a 12 centimetre spinal needle, and I think these can be very useful. One thing I would suggest to you is that sometimes if you're trying to do a spinal in a very obese parturient, a TUI needle can act as a very nice spinal introducer. Now, when should you do epidurals in these patients? Should you wait until they ask for them, or should you try and advise a very obese parturient to have an epidural early in her labour? Well, if you do the epidural early in her labour, you're certainly giving yourself enough time if it's going to take longer to do. And if the woman does need a caesarean section, you know that you've got a nice functioning epidural catheter already in place. On the downside, if you just decide not to do it, and wait and see, you've got if you do it too early, rather, there is the chance that because of the movement of tissue planes, the epidural catheter could become dislodged, so you'd have to end up resiting it anyway. My personal preference is to do it early. I think there's various Locket devices that you can use these days. Have you got Locket devices in Q8? Has anyone seen those? These are special adhesive devices that you thread over the epidural catheter, and it helps to secure the epidural catheter to the skin at the point of entry. They're as cheap as chips. You can buy them as separate devices, and I think they make a big difference to keeping your epidural catheter in the right place. So my personal preference is to do it early. Now, what about the provision of general anaesthesia to these patients? Well, we know it's going to be challenging. We know that everything is a bit more difficult. Vascular access, managing the airway, we know they're going to desaturate more quickly. So I just want to run through a few aspects of general anaesthesia. Actually, this applies to general and regional anaesthesia, but if you need to move your patient to theatre for an emergency caesarean section from a delivery room, for a category 1 or 2 case, I would really urge you to help be a member of the team that gets that patient to theatre. It can have a big impact on how quickly a woman is delivered. A hover mattress. Have you got hover mattresses in Q8? Would you use them routinely? So hover mattresses are devices, they've got jet-propelled air. You put a hover mattress under the patient. We use them for patients who've got a greater a weight of 100 kilos, and they make the moving of the patient much, much easier. I'm going to whiz through that. Now, I just do want to mention pre-oxygenation. It's essential to use adequate flows to ensure that you do denitrogenate the patient's lungs effectively. And one thing I would say to you is utilise your apneic period. In a very obese parturient, it's helpful before you induce general anaesthesia to apply nasal cannula. This can maintain some oxygenation while you're waiting for your muscle relaxant to work during intubation attempts. Now, one of the most important things that's come out in anaesthesia in general over the last few years is the THRIVE study. This is transnasal humidified rapid insufflation of oxygen. And basically, this is a way to deliver very high flows of humidified oxygen. Has anyone ever put nasal cannula in your nose? It's extremely uncomfortable. But the big thing about THRIVE is that it's humidified, so it's not uncomfortable anyway at all. So this group looked at using THRIVE in apneic patients. And I want to draw your attention to this time. 65 minutes of apnea time, and they maintained oxygen saturations at greater than 90%. My time is coming to an end, so I'm just going to head elevated laryngoscopy position, putting pillows under the head to bring the tragus in line with the sternal notch. Video laryngoscopes, I think, should be standard on labour wards. We know from many studies that video laryngoscopies reduces a grade 3-4 to a grade 1-2 laryngoscopy. Just to finish off, drug dosing. I think this is something we do very badly in all obese patients. I think there's a poor understanding in the anaesthetic community of what weight we should be using to calculate the dose. Total body weight, adjusted body weight, ideal body weight, or even lean body weight. And I think it's important that we become familiar with what type of body weight we should be using to calculate our doses. So for the induction agents, propofol or thiopentone, lean body weight is what should be used, and lean body weight is the difference between total body weight and fat mass, and there's a calculation you can do that to work that out. Adjusted body weight, which is ideal body weight plus 30% for alfentanil and antibiotics. But total body weight should be used for suxamethonium. So if you're using suxamethonium in a rapid sequence induction, just because it comes in a 2 ml, 100 milligram ampule, you may need to open 2 or even 3 ampules to give the correct dose of suxamethonium. In the post-op period, these patients should be extubated awake. Sit them up, reverse them adequately. And remember, they're going to be more at risk of infection, particularly chest infections. So do whatever you can to optimize analgesia with tap blocks. And bear in mind their risk of DVT is increased as well. So TEDs, flotrons, and low molecular weight heparin should all be standard. If you're the mother of an obese baby, your mother is really setting you up for cardiovascular risks later in life, but I'm not going to talk about that too much. So my take-home messages are, obese women have a higher risk of morbidity, and they do provide increased challenges for us with the provision of analgesia. But new strategies, and I really would urge you to look at THRIVE. It was published in Anaesthesia just over 1 year ago now. It's been one of the most important innovations in anaesthesia, regardless of what area you work in, can improve safety. Thank you for your kind attention.